think that we will be able to bring some things to bear on each of the different settings that you're coming from. Just general to start. Everybody's, I would imagine, is familiar with the DSM definitions of personality disorders at the moment. When people say that the main thing that they are seeing is the cluster B, fair to say? Yeah. What we find in general is that the people who are presenting here it's almost exclusively cluster B that we're seeing here at Spectrum. There are aspects of those personality disorders that seem to make them more likely to actually present in mental health services. But within each of the clusters, we see that there's quite a significant degree of overlap in the symptomatology. And are people aware of what's happening with ICD-11? Is this news to people? So there's actually a movement away from this diagnostic system in the new International Classification of Disease. Yeah. So the old model is this one where it's a tick box list of symptoms that lead you to the diagnosis. In this new ICD system, they're moving towards what's called a dimensional model of personality disorder. And there's a different emphasis there. So you still are trying to identify personality traits that are having an effect on somebody's life, but it's much more about psychosocial impairment as opposed to risk or any other of the really important things you look for diagnostically in the past. So this is potentially going to have a big impact on the way that we're managing and treating personality disorders. But for the purpose of the talks today, I'm going to stick with the classical definition of borderline personality disorder. And one of the reasons for that is because within this new system, one of the only diagnostic labels that's been kept from this old system is borderline. It's a borderline pattern. And the main reason behind that is because there are evidence-based treatments for borderline personality disorder. And so having that diagnosis leads you to those treatments. So the DSM-5 definition, pattern of unstable affect relationships and self-image with impulsivity. There's a few things that I think I'd like to highlight when I'm talking about this diagnosis. It's a commonly held belief that a history of trauma is a requirement of the diagnosis. But that's actually not the case. And it's quite a significant number of people that don't have a specific history of trauma but can still go on to develop the disorder. And if you look at most of the studies that are out there, there's actually quite a significant genetic component. The estimate somewhere in the range of 50% of the diagnoses can be explained by actual inheritance pattern. The people that are presenting to our services, 75% are female, but when closer looks at the epidemiology in the community suggests the disorder actually has a 50-50 split across the genders. And it's thought that the reason that we're seeing 75% here has to do with the way that the disorder presents in females versus males. So in many cases, the idea is that people who have a diagnosis of any social personality disorder may actually better fit the criteria of borderline, but men are more likely to get lumped into that category. There are also biological characteristics of the disorder. I won't go into this in a lot of detail, but there's the balance between different parts of the brain, the prefrontal executive processes, and the amygdala tends to be different in people with personality disorders. There are also hormonal changes having to do particularly with stress hormones that are at a higher resting state. But I won't go into a lot of detail about those aspects today. Prevalence. So most of the literature that's out there suggests that the prevalence of BPD is somewhere between 1% to 2%. It varies to a degree. Some say that it's higher. But if you take a population in Victoria of 6 million people, that means that there's at least 60,000 people in Victoria that would fit into the diagnostic criteria for BPD. And then amongst GP patients, this was the one that really got me. The estimates are getting up towards 5%. And so if you imagine that a GP sees somewhere between 10 and 20 people a day, that suggests that they're seeing somebody with BPD once in every 1 or 2 days, which then suggests that they're seeing possibly 2 or 3 a week. And then in a year, you're talking more than 100 people that a GP might see that would fit the criteria for BPD. In psychiatric outpatients, it's significantly higher, almost 1 in 10. But despite that prevalence, which is up there with any of the major psychiatric diagnoses, certainly up until the current time, it's been under-recognized, poorly understood, and inadequately treated. I want to stop there and just see if there's general consensus about this last point. People agree with that? Yeah? Anybody disagree or have any concerns about these stats? Would people say, yeah?
The only thing, I mean, and it's something that sort of puzzles or confuses me, is that you sort of, people say, oh, well, you know, they've got this sort of illness category, whatever, and borderline traits or both. I put them both up there in the diagnosis, and I'm like, which one is, what are we dealing with here, sort of thing.
Yeah, yeah.
But so, I mean, I suppose it touches on that point, so maybe it's represented in other diagnostic groups.
Yes. And I feel like you're sort of pitching that up in the air for me to hit it with the talk that I'm going to do.
Oh, well,
today,
yeah.
because that's exactly what we're going to get into.
Yeah.
Because you see it all the time. Certainly when I was coming through my training, it was very common to be in an emergency department or in an outpatient clinic and to read cluster B traits, all those sort of euphemisms
Yes,
that were out there.
Yeah.
My question's from your previous slide. How do you know that the 42 to 68% heritable are not nurture rather than nature?
It gets very tricky. So they've done some twin studies out there that when you break those down, they can say confidently that the variation is related to their common genetic background. But if you're interested in that, I'll have to get your name after and send along some of the studies for you, because it gets very complicated. But saying that it's 50% heritable, I don't think that quite does justice to that complicated balance that you're talking about. Because any one person, I don't think you could say that you could say to somebody, you have BPD and it's entirely genetic, or you have BPD and it's entirely because of the experience you've had. Both of them tend to contribute, if that makes sense.
I just figure it would be a real burden for someone with the diagnosis to think of their progeny.
Yes, well.
It is for anyone with a diagnosis.
Yeah, I know, but.
No, I take your point, yeah. So the issues that are commonly associated with the diagnosis of BPD. So high service utilization even without a full diagnosis. So again, this sort of alludes to this idea of BPD traits. And people that have even a hint of the diagnosis, they really need a significant degree of support. And the system in general isn't that well equipped to meet the need. And a lot of that has to do with the stigma that's associated with the disorder historically, which is an argument for getting rid of the actual name of the diagnosis. But at the moment, it tends to stick around because of the treatment that's associated with it. And now I've put that the stigma affects both consumer and clinician, and this is specifically because I think it's very clear how this stigma affects a consumer. I've certainly experienced it as well in the emergency department. The way somebody might talk about a person that has BPD can be flippant, to put it mildly. But I think that the issue with the way the stigma affects clinicians is that clinicians often come in with a sense that there's no hope, or that there isn't treatment that's effective for people with BPD. And so I think that the stigma affects them as well, because they come in with this nihilism about what they might be able to achieve, if that makes sense. There are high rates of self-injury, and the suicide rate is on par with the other major mental diagnoses that are out there. And then one of the big ones that's more than anxiety, depression, there's significant psychosocial impairment. Even if people manage to get out of the state that's associated with the self-injury and suicide, they often remain unemployed and unable to find rich relationships in their lives. And then the thing that we see here quite often with people that are presenting, they're often diagnosed multiple medications across different psychoactive classes. And a big part of that, I think, is because of the challenge in actually making the diagnosis and weeding it out from the other comorbid diagnoses that can be in the picture. And this is actually the issue that prompted the service here to do the little study that I've done. So what we chose to look at in more detail was the co-occurrence of major depressive disorder in people that have a diagnosis of BPD. Now, some of the studies out there estimate that major depression exists in people with BPD up to 50% of the time. And then if you take a group of people that have been diagnosed with depression, 25% will meet criteria for BPD. What I've put up here is I'm not going to tell you which one's which, but each one of these is either a DSM criteria for depression or a DSM criteria for borderline. And I don't know if anybody here knows which one's which of those, either one or two. Anybody guess or anybody know?
The middle one's BPD.
Well, if you say that, so what I've done is I put either the first one or the second one is borderline depression. To me, I look at that and I think it would be very hard to say what the difference is. And so this overlap.
It sounds like a trick question.
It was. Yeah, that's exactly right. But this overlap creates huge issues, and we'll go into that in more detail. One of the first issues is around the prescription of medications. So there is existing evidence at the moment that people living with BPD are prescribed antidepressants more often than somebody that has just a diagnosis of major depressive disorder. But despite that evidence, there's very little evidence to suggest that antidepressants are effective in people that have BPD and major depression. And when someone who has a diagnosis of BPD rates their depression as very severe, it's actually less likely to respond to antidepressant medication. Now, why this is happening? It's not entirely clear. But the thing that has emerged in the literature is that if you treat the symptoms of major depression as the primary issue, you're unlikely to see an improvement in either of the diagnoses. But if you treat the BPD as the primary issue, then what you see is an improvement in both symptom categories. Does that make sense?
Yeah.
So I'm going to go into that in more detail when we start talking about treatment principles. But when I first heard about this, I found it hard to believe. This didn't make a lot of sense. But the further that I've gone into it, you can start to see that the things like major depression, anxiety can actually be an expression of the underlying BPD. And then if you can't see past the surface level to understand what's going on underneath, then you're going to miss the opportunity to offer somebody effective treatment. So, with that in mind, the real reason that I've done this study is that there remains this stigma in diagnosing BPD. And we're also aware that there's some reluctance to make the diagnosis when it tends to come out in adolescence. And so there's a concern that this diagnostic issue actually contributes to delayed diagnosis, ineffective treatment, and ultimately a longer period of impairment and a longer period of being at risk. And so we're thinking about how to look at it. So this is the general structure of the clinics here at Spectrum. I'm not going to go into this in a lot of detail now, but we can talk about it towards the end if people have questions. But what to take away from this is that we take referrals from area mental health services, GPs, and private psychiatrists as our primary intake. And what I've used for this study is people that have been referred for a full assessment, a 291 assessment. People know what that is? A 291 assessment is a Medicare item. And it basically means that people refer for a psychiatric assessment, and it's a full assessment. And we do those here for GPs that refer people in. And so everyone that I've looked at in this study has been referred by their GP to consider a diagnosis of possible BPD. So every time I saw somebody for one of these assessments, at the end of this session I would say to them, we're doing this study about depression and BPD, I was wondering if you would be willing to fill out a couple of depression rating scales. And the ones that we use commonly here is, the first one is the BDI, the Beck Depression Inventory. People have heard of that one? Yeah. It's a gold standard consumer rated scale. The other one that I've administered is the Hamilton Rating Scale of Depression. That's a clinician rated scale, so that's the one I've got in my hands. The third one here is the Quick Inventory of Depression. Now, this one's been included as a type of control. So the Quick has both a client rated and a clinician rated scale that have the same questions. And so the idea is that if you have any kind of bias in the clinician looking at it significantly differently on objective questions, you're going to pick up on that here. Does that make sense? Yeah. The K10 is a very commonly used general survey for potential mental health problems. My impression is that it's used quite commonly in primary care. Would people say that's fair to say?
GPs use for.
Yeah. And then the BEST is a tool we use here. It's the Borderline Evaluation of Severity over Time. It's a scale that allows us to assess for the severity of symptoms of BPD. The inclusion criteria for this were a positive diagnosis of borderline personality disorder majoring in the assessment process. And that's pretty much it. And then they had to agree to participate. And it was fairly straightforward. Yes?
I didn't want it to be passed. What I heard, that GPs can refer.
Yes.
Thank you.
Well, look, I've got that slide right at the end, so that when we get to there, we can talk about all those sorts of referral pathways and how the clinic here works. Because I find that almost always comes up when I do these talks. Is that all right?
Sure.
Yes.
The intake procedure, how many hours is that?
So the assessment, we block out anywhere from 60 to 90 minutes for those assessments. But there are times when cases are more complicated and I'll actually see someone more than once.
And that includes then doing the questionnaire?
Yes. Yep. In general, I found that doing the questionnaires took about 15 minutes, all up. So 22 people agreed to do it over the 3 months that I did the study. Everyone agreed, which I was surprised by, and that the number of women and men was about consistent with what we see in the usual presentations to the clinic. The age range was all the way from 18 up to 73 with a median of 33. And significantly, 17 of the 22 were prescribing antidepressant at the time of assessment. So, what we're looking at here is each one of these scales actually has a different number of rating categories. So some of them have 6, a couple 5, and one of them 4. And so instead of actually splitting them up according to that, what I've done is you're looking at the number of ratings that came back that use the word severe or extreme in describing the mental health problem that the person had. Yeah? And so out here on the left is the K10. This is the client-rated scale that's used in primary care. This is the client-rated scale that we use here at Spectrum. These are the two that are the ones that have the same questions. And then this one is the purely clinician-rated scale. And what you're looking at is, as you move from the clinician-rated scales to the client-rated scales, it's a significant change in the level of severity that's being reported. When you do the stats on it, it did come out as significant, even with this small sample size. So a significant result here, when you see these little asterisks, means that they significantly agree. So they're not different, they're actually saying these are likely to actually be the same. And so up the top here, we've got the BDI, the client-rated scale, versus the 2 clinician-rated scales. And you can see because there's no asterisks, it means they're significantly different, or it's suggestive of that. Where when you come down to the BDI versus the other clinician-rated scales, they're suggesting that they're the same. And very importantly, the one that has the same questions, the stats are suggesting that it is the same, even though when you look on this graph, they look different. At the moment, the data is suggesting that there's not significant bias in the clinician looking at this when you compare those scales. Does that make sense? Yeah. So as another way of looking at the data, I've correlated all of the scales with the evaluation of symptomatology for BPD. So this is everything here is compared to borderline personality disorder symptoms. And what it's suggesting is that as borderline personality disorder symptoms go up, that a higher number here means that the scale goes up as well, the rating scale. And so what you're looking at again is that the K10 and the other client-rated scales are better correlated with symptoms of BPD. And so basically if you have a greater severity of BPD, you're more likely to report a higher level of depression. So what does it mean? Does that all make sense? I mean, I feel like it's a very complicated way of saying something that's actually fairly simple when it comes down to it. But what it means, I think, is what the implications it has for our understanding of BPD and our approach to treatment is quite significant. Because as we know, people living with BPD are often desperate for support and treatment. And that in some situations, if someone's feeling uncomfortable about making the diagnosis and they give somebody a rating scale, and that rating scale uses a particular language, that person may be likely to then use the language of that rating scale to express their level of distress. Do people go with me on that one? Anybody disagree, comments, or?
You're sort of saying that as someone who's feeling distressed related to their personality issues might use depression-type language to convey that in a sense.
It's a concern. So it's just an early, this is a very small study, but there's certainly been a suspicion that this process may be happening.
Okay.
And we're staying within the bounds of depression with this particular example, but the suggestion is that you could extrapolate it outwards to other symptoms. If you were to ask somebody about symptoms of psychosis, or ask somebody about symptoms of bipolar, but you may get the same process happening. But we don't know that for sure. And then we're going to go on to talk about how this potential confusion has implications for treatment approaches. And the first one is the prescribing. And as I said, if I were somebody that didn't work with people with BPD on a regular basis, and somebody came in and they gave me back a K10 that said I had extreme symptoms, I would want to do something. And I think that in many cases, something that seems like an active way of treating is prescribing medication, particularly if the suggestion is that person has depression. And so we look at this sample of people. 17 of them are on antidepressants. If you take the Hamilton, the HAM-D, the Hamilton Rating Scale of Depression, according to the literature that's out there, only 2 of them actually met the tipping point where you start to see that antidepressants are actually indicated. And those 2 people with the high scores, actually, they also had the highest scores on the best. And so there's a real concern that there's a number of people that are being prescribed antidepressants that it's questionable about whether or not they really need to be on them.
So you're suggesting that that's a function of just, say, a single presentation or a couple of presentations where if they'd gone through the full diagnostic process, they would have done the tests?
It's hard. I mean, this is a cross-sectional.
I didn't say suggest.
Yeah. I mean, certainly this is a cross-sectional assessment, and so when I see this person and feeding back things to whoever's referred to them, I'm not going to say this person's inappropriately on an antidepressant, you should stop. No. But certainly I think it underscores this concern because really, I mean, I think from my point of view, the big issue is that if you put somebody on an antidepressant and you're waiting 2 months to see whether or not it's going to be effective, that's 2 months when they're not having other treatment that might actually be more effective. And then this is the one where I'm very curious about other people's opinions in the room. This, coming out of the discussion about prescribing of medications, there's this worry that a focus on more biological interventions, things like ECT, admissions to hospital, medications, might actually delay the provision of long-term psychotherapy. And then there's also the issue about the type of psychotherapy, even if it is considered. And so, the gold standard of psychotherapy for depression remains CBT. Now, the evidence for CBT within a population of people with BPD is not that strong. And I was curious as to if anybody has a guess as to why.
I don't know, when I was working, where do I start? A lot of times people report a CBT approach when they're not necessarily just using an approach. That's one problem. Having worked in hospitals where lots of the team, the psychologists there were sort of saying, well, we're calling it CBT, but we're doing other things like throwing a bit of DBT, throwing a bit of, some sensory motor psychotherapy, whatever. I think the whole thing about CBT is problematic because it's not manualised. There's no standard way to teach it and to know what people are actually doing when they say they're doing CBT. So that's one problem. The other problem is that if we hold the idea that BPD is primarily a disorder of, one of the things is emotional dysregulation, which is how it's described, then just doing cognitive behavioural work may not be adequate. Much more need things like, inner family systems work or, the work of Janina Fisher, that sort of thing, to work with, and parts work and that sort of thing would be much more effective, I think, than CBT.
Yeah.
And less stigmatising as well.
Yeah, I agree with you.
Yeah.
Yeah. Anybody else have any thoughts?
There's something about the nature of, recognising a cognitive distortion for what it might mean for that person, being really difficult when somebody hasn't really got their bearings as to a solid baseline where they can compare themselves or at better times, or where maybe the comparison in terms of Socratic questioning with other people just doesn't carry that much weight, possibly.
Mm-hmm. No, I think you both have hit on really important points. Before I sort of launch into it, does anybody else have any thoughts?
I'm just wondering about the nature of therapeutic working alliance with someone. If that was really well established and there was some relational work going alongside the work, it might be effective, mightn't it? And a place to practice those skills as well.
Yeah. I should say Joe works here. So anybody else? Yes.
Correct me if I'm wrong, but I think with CBT and depression, you've got a clearly defined thing you're working on in form of negative thoughts, usually about the self or one's life. So this borderline situation, what is it that you're working on? What thoughts? Many of them are interactive. They're not. So how do you pick which thoughts you're going to use your CBT against? And if you get the wrong ones, it's going to be very helpful.
Yeah, that's exactly right. Look, all the points have been really great. To my mind, there are a few issues. One is about the length of treatment, and that it's quite a contained treatment. You're coming in for this many sessions usually, and we're going to be talking about this very specific thing. And that the discussion of cognitive distortions and negative thoughts is often the language that's used in that environment. The problem with that is that people with BPD often come in to psychotherapy environments with their guard up. This is, I don't know how this person is going to respond to me. I don't know if they're really going to understand what I'm going through. And in many cases, understanding and making sense of emotions can be incredibly challenging. And so if you take somebody into that environment and you say, okay, tell me what your problems are, and then, okay, well, that thought that you're having is clearly distorted and negative, and we need to change that, that can be incredibly invalidating. You know, immediately having this reaction of somebody else telling you that you're broken and that you need to change. And so this is the really essential thing that differentiates what they call the second wave psychotherapies from the third wave, which is things like DBT, ACT, MBT, all the other treatments that have very robust evidence in the treatment of BPD. And so this what you've all mentioned, it really strikes at the core of what we think is actually going on in psychotherapy, is that this core need to validate and to understand is incredibly therapeutic. And then my next question is, do people think of as psychotherapy as being passive? And I mean here versus something like medication, admissions to hospital. And
Not if you practice sensory motor psychotherapy.
okay,
It's very active and very present in the moment.
yeah,
Yeah.
I don't know much about it. Would you say something about it?
Sensory motor psychotherapy isn't, oh dear, it is using the person's present moment experience or not of their bodies as part of the work, so it's quite non-verbal at times, but you're asking the person to, it's like supported self-study. You're not putting your hands on them or anything like that. Some people think it's massage or something. It's nothing like that.
Yeah.
It's just a very mindful-based approach to understanding. It's a bit like, have you ever heard of Focusing by Eugene Gendlin that was around the 80s? It's a bit like that in that you look for tiny shifts inside as you talk or don't talk about certain things. There's a lot more to it than that.
Yeah.
2.5 years of training, but I still don't know how to describe it.
Yeah. That sounds really interesting.
Yeah.
Anybody else? When you're seeing somebody, I would assume that everyone here is at some point or another had some contact with somebody living with BPD. Do you think that do you ever have a sense that you need to do something in those situations? That you need to be arranging for treatment, or you need to be prescribing medication, or does that ever come up? That sense? Do you ever think it's enough to just sit with somebody and listen to their problems? Or would that seem like a...
But that's relational, that is listening, it's active listening, it's more than just words going in, it's thinking about and relating and validating and trying to understand.
Yeah.
It's very active.
Yeah. Well, I think yours is quite a unique perspective, though. I don't know that naturally occurs to people. It's certainly not my experience when I was coming through training in more general medical circles. Is that the
Are
idea
you going to
of-
divide people up as clinicians, consumers, onlookers, family, friends?
Well, I'm just curious as to what people think about it, because I've often seen, my experience has been is that this can be an issue in terms of thinking about how you're going to help somebody who has BPD. Is that sometimes people feel like they need to do something, and that it can contribute to this sense of nihilism that they don't know what to do or how to go about it.
But there's different types of psychotherapy. For example, I don't think psychoanalytic psychotherapy is going to be very good for someone with BPD, because I think some aspects of it, like if it's done traditionally and the person's lying with their back to the therapist or whatever, that can be quite shaming or isolating for the person. So first of all, psychotherapy is quite an undefined term. But the other thing, somebody was talking about relationality. Still, the common factors tell us, Wampold and all of those researchers who've done all this meta-studies tell us that the relational stuff is the number one factor, and hope is number second.
Yeah, that's exactly right.
And I don't think there are too many practitioners who would sit like the Freudian joke with their back to the patient. I think, the therapist being able to contain all that anxiety and distress and to try to think about it is very important for the patient. Try not to get panicked unreasonably, but to keep, trying to hold, to contain, and also to help with the boundaries.
So what to do in practice? Because we go back to the NHMRC guidelines from 2012. In terms of the times when you should start thinking about the diagnosis of BPD, anytime you see frequent suicidal behavior or non-suicidal self-injury, anytime that there's marked emotional instability, multiple co-occurring psychiatric conditions, and I think quite significantly, non-response to established treatment of current psychiatric treatments, and a high level of functional impairment. Anytime, I just would hope that it would run through your mind that might be the diagnosis. But as I said earlier on, the comorbidity is almost a rule within BPD, and so many times you'll look at their record, and you'll see many different diagnoses on there. That can often be a little signal that you should start thinking about BPD. The ones that we see commonly here: bipolar, schizophrenia, attention deficit hyperactive disorder, autism, depression, PTSD, and eating disorders. Do people find that this is consistent with their experience, seeing these different disorders? Any standouts? Any ones that you think appear more often than others?
PTSD.
Yep.
Eating disorders.
Yep.
Right.
Anybody have any idea about how you would tell the difference? How you would know if it was BPD or any of these other disorders? Does anybody have a way that they think about it? Like, oh, that's probably a sign that it's BPD over whatever the other diagnosis is.
I think sort of colloquially, people say, oh, I got a good rapport, or I felt sort of good boundaries or something like that with the person. So I don't think that there's a borderline factor here, and if they feel that the person is sort of dependent or manipulative and things like these are some of the terms that then they might sort of say, oh, maybe there's a bit of BPD in the mix type thing. I mean, that's the way people talk in a sense.
Yeah.
Yeah.
That's exactly
so
right.
it's kind of this sort of, I suppose, just a interpersonal kind of feeling, reaction.
What usually happens when you have that kind of interaction, where somebody may have another diagnosis, but then somebody will say there are BPD traits in there as well. What, in people's experience, do they find that those BPD traits get addressed directly, or does it tend to, the focus sort of stays out on the other diagnosis?
Well, I've seen some terrible things happen in hospitals with different labels and incorrect diagnoses and things like that. So personally, in my private practice, I try and avoid labels as much as I can. Just work with what is presenting in the room.
Yeah. No, I agree with you. I mean, this again, it's a bit of a trick question down the line, because I don't think that there is a real answer to this. But the point I'm trying to make here is that this is very common. It's very, very rare that you're going to have somebody that has just a pure diagnosis of BPD. And what I want to emphasize here is that historically, I think that once you have one of these other diagnoses, even in the old DSM system, it used to be Axis 1, Axis 2. And so if you had one of these diagnoses, it overshadowed the personality disorder diagnosis. But what's emerging is that doing that can actually miss the real meat of the issue. And so what I'd encourage you to consider is that even if you see these other diagnoses on there, and it can, sometimes it can be severe schizophrenia, severe bipolar, if you think that there are BPD symptoms that are contributing to the mix, it needs to be a priority. And it needs to be treated specifically, as opposed to just considering it to be kind of a side product of whatever the bigger diagnosis is.
I work with a lot of patients with schizophrenia, and I found exactly what you said, that they get diagnosis of borderline personality disorder, but not many clinicians really know or want to address. So schizophrenia, that's all their attention.
Yeah.
And a lot of distress is actually can be explained by borderline personality
Yeah.
disorder, but it doesn't get addressed.
Yeah. And so, look, there are cases where it is schizophrenia. I'm certainly not saying that everybody has a personality disorder, but those ones where it goes unexamined for a long period of time, so sometimes you're missing out on an opportunity. There are specific tools that you can use, but a clinical diagnosis remains the gold standard for diagnosing BPD. One of the ones we use here quite commonly is the BPQ. It's quite an in-depth diagnostic tool. You can probably send something around about it to some background literature if people are interested. The other one that's much briefer is the Zanarini scale, which is a 10-question tick box survey that you can use to start thinking about BPD. Does anybody use these ones? No? So this is where I'd start. I mean, we use this quite commonly, particularly if we're looking at a second opinion where there's diagnostic uncertainty, and we want to support the case we're making for the presence of BPD. We'll often use this one. But this one is as well. We can often encourage people to use if outside of spectrum when they're wanting to start to do some initial investigation. So as I said before, the most important step, the critical thing to do, is to make the diagnosis of BPD one of your priorities if it's present. It doesn't have to be the priority, but you need to be thinking about treatment if you think that it's there. But then there's this big issue about access to treatment and to training. And so, I'm hoping people will comment about what they do when you have somebody, you see somebody and you think that they have BPD. What do you usually do in terms of trying to engage, thinking about referral pathways? I don't know if anybody has a specific approach.
With young people at Headspace, I sort of follow the protocol of doing some emotion regulation exercises and do distress tolerance, mindfulness, some assertiveness training, that kind of stuff. Yeah.
That's great. How's that go?
Yeah, good. Yeah.
Were you trained in that specifically?
No, just from all the kind of sort of research and training that I've done, a lot of CPD and just sort of and we have a really good group on a Friday with the other psychologists that are there, and also we've got the psychiatry, the registrars, and so we have a really good peer consultative space. So we're always sort of sharing and discussing and trying different things. So
Sounds
yeah,
great.
yeah.
Yeah.
I remember I saw a couple of years ago Marsha Linehan had come out and Linehan and I remember just some pivotal things that she had said and in terms of suicidality and how she chooses not to work with it predominantly, and she sort of is very clear about that from the outset. And then she said that no matter what it is that you're doing, as long as you're kind of targeting those key, those key parts of the treatment, she said that you will have success with treatment outcomes. So
yeah, that's exactly right. Yeah. Yeah. She knows what she's doing. Yeah.
She's interesting.
Anybody else? Where do you refer somebody if you think they've got BPD? Or do you?
I have to say I don't, because I think the waiting lists are so long that I think what's the point? Just try and keep them engaged and coming in, even if that means, seeing them pro bono once they run out of their 10 sessions. That seems to be what I'll have to do at the moment. So I'd be very interested at the end to hear about what the, you know, what the story is about waiting. And, you know, sometimes they need inpatient because they have drug issues at the same time. And so it's, that's my issue really.
It's challenging,
is where, yeah.
And thanks for doing that.
Yeah.
Yeah. I will talk about that, if that's all right. I'll stay
Yeah.
until the end.
Mhm.
Anybody else, where do you refer to? If it's, has anybody referred to Spectrum?
I think sometime I have in the past. I mean, I have a small private practice now because I'm sort of moving slowly towards retirement. I guess I've had 1 or 2 people with borderline personality disorders on my books at any time. And I do see them regularly, at least once a week and occasionally twice a week, if they're in a position to do that. And I think that's, and it's long-term, the way I work.
Yeah. Okay. Look, I will talk about some general treatment principles. This is the way we tend to think about it here. I'm certainly open to discussion if people have other approaches, thoughts about specific aspects of this list here. But the first thing I usually think about is discussing the diagnosis with the person that you're seeing. And this can go, I find that this can go one of a few different ways. One is that they say immediately, yes, finally somebody is describing what I've been going through. This is a miracle. How do I start accessing treatment? It can also be, no, that doesn't describe me at all, and I don't want that label on me. I don't want that following me around. And then there can be something in the middle where there's a bit of ambivalence about it. But in all cases, I think it's really important to actually talk about what you think is going on. And then you can work together to a common understanding about what the situation is and where you're going to go with it. The mainstay of treatment,
I'm stunned to think that there'd be any clinician that wouldn't do that.
well, certainly not. Certainly,
I would hope there wouldn't be many.
certainly not historically. I mean, in the past, it used to be something where, as I say, you'd read on somebody's file these sort of innuendos that they had cluster B traits or whatever else it was.
The innuendos are still happening.
I've heard,
I can believe it.
I'm not a clinician, but I've heard, going to circulate in this space. Some people do, I'm sure I've heard, some people avoid saying it to them and just try and work on it.
Yeah.
I have lived experience, and that's what my primary physician did with me. At first, she didn't want to discuss the name of it because I had a lot of internalized stigma about having any mental health issues, and she knew the pejorative nature of it. And then it wasn't until I was in another sort of treatment that another clinician told me.
Was that a relief?
Yes and no. I mean, at first it was terrifying because the symptoms listed, I really didn't want to be my life going on. But then at the same time, it gave me better options for treatment that actually meant that I could manage that part of my diagnosis.
Yeah, so look, there are certainly times where when you start talking about it, you can have a strong reaction to the idea of the diagnosis, but I've yet to have a situation where I regretted it ultimately. It's just having that open honesty is all part of building the bedrock of a relationship that's going to allow you to work.
Well, I had one person I saw for a number of years who had a long history of hospitalizations, God knows, every treatment you can imagine. And her determination was to get rid of that diagnosis. She found it so stigmatizing. And she finally left on PTSD, I think. Admittedly, she had horrendous history. I mean, I'm not much preoccupied with labels. I am preoccupied with trying to understand what's going on. But I do think there can be a lot of stigma about, I've worked in psych hospitals and I know the way people talk about borderline, she cut herself, just wants attention or whatever.
Yeah, I mean, the label, certainly the actual name is really an anachronism. I mean, it's been around for a long time, and I don't know that it's at all accurate in describing what's going on, but most of the time, if I find that somebody's not identifying with the diagnosis, that pitching it as a way of identifying appropriate intervention can help. Saying like, look, because I don't actually like the term, but if I say to somebody, I don't like the term, but I know that if I actually state this on your chart, then you're much more likely to get treatment that's gonna help you.
Yeah,
And then
you're in that setting.
You can connect a little bit.
I'm wondering as well whether it's something to do with the fact that we don't generally do those scales, and we don't arrive at a really definite diagnosis, so it remains in that realm of, oh, this belongs to cluster A, B or C. So that uncertainty then kind of leads to not being certain about how to explain that, whereas I think if we had a proper diagnosis, then we can also explain in detail what that means, and that may actually be helpful to some people.
Yeah. Well, I'd be very interested to hear what people with lived experience have to say about this, because it's one of the things that I think is important to convey to somebody when I'm making a diagnosis is that the actual word is very impersonal, but the experience of what they're going through is unique in all cases. And so actually discussing the diagnosis, and so I often leave upwards of 20 to 30 minutes at the end of an assessment to actually leave room for us to go back and forth about the diagnosis.
I suppose relating it to the real life suffering
Exactly.
that they're experiencing and why, and
Yeah.
then having that motivation that comes out of that.
Yeah. And that can lead to a much deeper understanding about what's actually going on, as opposed to these old criteria.
It's really about the delivery, isn't it? And I guess with any other diagnosis, cancer, that's not a nice diagnosis to hear, but the person has a right to know we're providing a service. We need to invite them to find out more about themselves, don't we? So, yeah, they can make an informed decision about it,
Yeah.
can't they?
Well, it can be tough though, because if you make a diagnosis and you haven't laid some groundwork, they'll go out and Google it, and oftentimes what they'll read will not be what you would hope would be the key elements of the message you're trying to convey.
Well, here's the delivery, and here's some people with lived experience that you might want to listen to on the net.
I just tell them to go to the BPD Foundation.
Yeah, that's right.
Okay, so the mainstay is psychotherapy. So this is not to suggest that medications don't play a role in treatment, especially if it's if they're a true comorbid diagnosis. But as soon as you're thinking BPD, you need to be thinking about psychotherapy. As I said, limited evidence for antidepressants, and in general we try to avoid medications that are dangerous in overdose, and that's benzodiazepines, opiate medication, some of the antidepressants in particular that can be quite dangerous if taken in overdose.
Serocal's pretty bad if they take a lot of it too.
It's up there, yeah. I mean, none of them are great. I mean, I've yet to come across a medication that's wholly benign. So you just got to be careful. But there's certainly times where it can help. And I've listed a few of the ones that actually do have a bit of an evidence base, but they all have significant side effects. And so you've really got to weigh up very carefully the benefit and the downside. And importantly, I think that if you've got somebody that's really having a hard time, it's important not to think of being admitted to hospital as a failure. This is something I've often seen in treatment plans that think of it as a sign that either the clinicians or the person living with BPD has not lived up to their end of the bargain. Particularly in the early stages of treatment, that can be quite destructive.
Surely if it saves your life, it can't be seen as a failure.
Yeah.
You see, saying it like less traumatic situations.
Well, look, and that's exactly, I agree with you completely. And in many cases, that's what it does. So particularly in those early stages, getting down on the idea, because you'll often hear people talking about resource utilization and that being this major issue that we've got to stop. But ultimately, if a person's life is at risk, we've got to respond appropriately.
First of all, you've got to have a patient. You've got to be alive.
Yes, yes, you can't do psychotherapy.
That's help,
with it.
doesn't it?
But there's actually good news associated with the diagnosis of BPD. It's another reason why I like to make the diagnosis sometimes, is because I can say to somebody, compared to all the other psychiatric diagnoses that are out there, this one has a remarkably good prognosis, if you can survive the risk.
Well, you've won the lottery here.
I know. Well, it's certainly not as simple as that, but the idea is that if you get a diagnosis of schizophrenia or bipolar, it's likely to be something you're going to be living with for the rest of your life. Whereas if you can survive periods of risk and get into appropriate treatment, there's actually quite a high likelihood that you'll go into remission. Now, I should define what remission is, because it's different than recovery. Now, remission basically means that you're coming out of a period where you're at physical risk. So the admissions to hospital, any self-injury, suicidal thoughts. What we find is that by 10 years, most people, the majority, that's stopped. But the problem we've still got in the treatment of BPD is that most people have not recovered. And what that means is that most people still are not working regularly or maintaining intimate relationships, and not necessarily romantic, but just those tight relationships. And that's really the next target for treatment. Also keep in mind that substance use is a major barrier to recovery, particularly this is a shorthand for alcohol. And so with that also, if you see somebody with BPD and they're drinking quite heavily, it really needs to be a priority in terms of addressing that as well. But the things that people have touched on here today it's really great to hear, because the main message is that therapeutic interactions are possible in any environment with some knowledge of common factors, which got mentioned just a minute ago. I would imagine that most people have heard of common factors. Is that fair to say? Yeah, if they haven't, how much time have I got, Rita?
10 past 7.
Am I doing okay? I'm winding up.
Check with everybody else.
We're doing okay?
Yeah.
I'm getting towards the end. So the common factors, there's evidence base is out there now that suggests that all the specialist treatments, DBT, MBT, ACT, schema-focused therapy, they all have good solid evidence, but there is some evidence out there that suggests that there's an underlying structure of them all which makes them effective, and which can be used by anybody, anywhere, in any setting. And these are the major points. So I'll run through them, but and try and explain a little bit about it. But this is like a 2-day workshop to really understand this in any sort of depth. But structure basically means that you're working inside a specific psychotherapy, so you have some sort of base from which you feel confident in the work that you're doing. And it actually doesn't matter what it is. You just need to feel like you have your bearings in working with somebody that is living with BPD. Validation, this probably above all. The idea that you can reach out to somebody and make them feel like you really understand, and that the way that they feel is reasonable, is an absolutely critical part of successful therapy. Encouraging self-observation. This is a two-way street, so you're encouraging the person you're working with to reflect on what they're experiencing, but it falls back on the therapist to reflect on the way that they're feeling and respond to what's going on. A clear treatment framework. Now basically what this means is that you have some sort of structure to the way that you're engaging with the person. So it can be as simple as, we're going to have sessions for this long, it's going to be in this place, and we're going to meet at this regular interval. And that needs to be very clear. Because if there's any uncertainty, I'll get back to you now and then, or we'll see how things work out, it can really undermine a sense of security. Attention to affect. Everybody familiar with the term affect? Basically, your emotional state. So the idea is that you, as Marsha would say, you attend less to the actual specifics. So I think in her example of saying the suicidality, the suicidality is a really important thing to be thinking about in terms of risk. But what she's getting at is that the suicidality is an indication of an underlying emotional state. And what you're really wanting to do is drill down past the suicidal thoughts and into what's actually happening for that person underneath it. A focus on the treatment of relationships, so this means you're an active therapist, so these two go together really, in that you actually say to them, how are we doing? What's happening between us right now? Did you understand what I was trying to say? I didn't quite get what you meant. Tell me more about it. And that drives the exploratory and change-orientated intervention. So you're thinking about what's happening together, saying, oh, does that make sense? Does it not? Do you think maybe that we could think about it differently? And then the things that are really important to have as a support structure to it all is a well thought out and agreed crisis management plan, particularly if there's significant risk involved. And so that means actually writing it out. So if this particular scenario happens, this is what we're going to do. So there's less chance of surprises if things get difficult. Supervision for the therapist, really important. You've got to have a space where you can let it out, because the work, it can be very difficult work for both people. And so it's very important that you've got a place to reflect on what's going on. And then if it's appropriate, support for families. It just as a baseline now, we really try to involve families in understanding what's going on with treatment, psychoeducation as much as possible. Because a big part of the issues that people living with BPD run into are about relationships. And so if you're not addressing that extended part of who they are, you're missing part of the picture. Improving your skills, you can take those common factors and you can run with them. You can do a lot of really great work in whatever setting you're in. But if you want to, it's a very deep rabbit hole to go down in terms of training in specific psychotherapies, picking up different skills. The ones we talk about as being the big four are TFP, MBT, DBT, and SFT. Is everybody familiar with those acronyms? Transference-focused psychotherapy. So this is it's a psychodynamically informed therapy, one-on-one. Started in the States. Otto Kernberg is the big name. There's very few therapists that are trained in TFP in this country, so this one's hard to find. But what I found is that doing the training, whether you turn into a TFP therapist or not, can be extremely helpful. MBT, mentalization-based therapy. We have an MBT clinic here, and we do training here. DBT, we run training workshops here as well. Schema-focused therapy, we don't do that here. I'm sure you could find some sort of training around. And ACT, which is homegrown, and we have ACT programs here as well. And as Rita was mentioning, it's a very exciting time to be involved with the field of treating and understanding personality disorders. The knowledge base is expanding rapidly. There's actually money coming towards it now. We're finding that the number of referrals that we're getting are really shooting up, which is contributing to part of the challenges. But we are really hopeful that the Royal Commission and a number of other strategies that are in place are going to mean that things are going to change significantly in the coming years. And significantly, RANSAP, the College of Psychiatrists, has just approved a section of personality disorders as well, which didn't exist in the past. Okay, so I'm done talking, unless people have questions about the referral pathways, because I can talk to you about the structure of Spectrum and how you can access treatment, but I can say right from the beginning that we do have a challenge in terms of wait lists. So.
Can you just go back to the comment back there?
Yes.
You know, I've got probably an unpopular position here, but I would argue they're not common factors of psychotherapy, they're common factors of professional-client relationship. I mean, I would want that with my accountant.
Certainly,
and
they're common
there should be a
factors.
minimum standard, like therapy, what comes after that?
Yeah. Yeah.
Sorry.
No, you don't have to be sorry. I agree with you. But I mean, but I think, you know, this audience in here is there's a bit of a selection bias in here, because I think to a lot of people, that many of these things would seem plainly obvious. But certainly in my experience, this is actually quite rare to see in a lot of settings.
Just picking up on that, it's almost like there's an opportunity for treatment, for the approach in this area to be a pocket of excellence within mental health, because
Yeah.
you're kind of trying to show the way.
Yeah.
Is one way of looking at it, maybe.
Well, this is why I say that the rabbit hole is quite deep, is because it's like being an athlete. You know, you can be a casual weekend runner and that will maintain your health and keep you well. But you could also go all the way down the rabbit hole and end up being an Olympic sprinter. And there's all sorts of different levels in between that. But even if you're just a casual weekend runner, you're going to maintain your health and you're going to be doing good things. And so these principles are just the starting point. And I completely agree that this is a very sort of basic expectation that people living with BPD should have of their therapists.
I guess, Lucas, I'd just like to add another thing that can be very helpful for people to look outside the sort of the psychological therapies, but things like yoga, for example, things like trampolining, things like volunteering for animal aid or whatever actually helps a person to be in relationship with others or animals.
Yeah, it should be on the list really.
Yeah.
Yeah. Because yeah.
One of the things I was interested in is the lack of dialogue about the role of trauma here. I come from that sort of field, but given that not everyone with BPD will have a trauma background, that's true. But what about the percentage that do have a trauma background? How is that specifically addressed here? I'm kind of interested in what Spectrum does in relation to trauma.
Yeah.
I would be more inclined to say that just as there's perhaps the clouds in between being able to have a clear diagnosis, I think it's the same cases that when people may not be skilled in being able to name that there has been trauma that they haven't been able to name trauma.
Well, yeah, that's right. I mean, a lot of people, the studies show that it takes 8 or 10 years before, for example, childhood sexual abuse and that sort of thing are known to the person that it happened to.
Do the studies address things like that the trauma may be underreported, for instance, or underdiscovered?
Yeah. So
Well,
look,
it's not reported, it can't be.
it's quite a complicated issue.
It's very complicated issue.
Obviously incredibly delicate in terms of addressing it. The way, certainly within the way that we do it now, is that it's often up to the person as to whether or not they want to go into it. Now, certainly, if you take something like DBT, the main message within the classical form of DBT is that you do not focus on the trauma, certainly not to begin with, and that you need to build a base of the therapeutic relationship and of skills that are going to allow you to start to look at the issues of trauma with some structure there. Now, there is a specific form of DBT that's targeted towards PTSD, and that we're seeking out some supervision around actually establishing a group that's going to have that sort of credentialing to do that work. But there's also a similar process that has emerged in the literature to what I was saying about symptoms of depression being steered by BPD, in that there is some evidence that suggests that if somebody has PTSD and they have BPD, if you treat the BPD, the symptoms of PTSD tend to get better whether or not you're actually addressing that trauma head on.
Well, I would say trauma treatment 101 is you don't go directly toward the trauma anyway. That's just sort of basic, the foundational stuff that you talked about, that we've been talking about, which is stabilisation and safety and structure and all of that. That's beginning of trauma work anyway. But there's different types of trauma. For example, there's attachment trauma, and then there's sort of single incident trauma. There's lots of different ways that trauma can present. So I'm sort of just wondering where in this, I see there's support for families there, which is great, because some of it's systemic. Some of the causes of what we call BPD, I think, are quite systemic. makes sense in their family of origin to have those symptoms, that's how they survive. I'm just not quite sure where spectrum, where they sit on that trauma, whether they're trauma informed. I mean, I guess that's why I'm here, to try and find out where you guys are sort of sitting yourselves.
Yeah, I mean, so historically, the treatments for BPD have tended to focus on the here and now and to leave the trauma a bit more to the side. But it's an area that we're planning to expand into. And particularly with the overlap between BPD and the new diagnosis of complex PTSD, in many cases I think they're almost analogous. And so we are actively seeking out to actually become a center that targets trauma. But that's still evolving at the moment. And so in terms of answering your question, I don't think I have a firm answer right now. I don't know if that's very satisfactory.
Well, that's why I'm here to find out where you're at. Yeah, that was sort of my impression of spectrum anyway from a distance, so, it's good to know where you're at.
Yeah.
I guess that I would just like to make a point from a carer, because that's the perspective that I'm in this space, that it can be extremely traumatic for carers to have clinicians focus on the cause of the trauma. And
but that's not what trauma work is these days. We don't go and poke the sore spots.
Okay, but I run carer workshops here, and we have a number of carers that come to the workshop that are extremely distressed because usually their child's therapist has been wanting to know what's happened to the person. And it has actually aggravated the trauma. And I could, for the parents, they're often already extremely stressed trying to cope with whatever's happening in their life. Yeah. And all they often need is just some skills to help them to be in a better relationship.
Of course, that's why I just finished a Masters in Clinical Family Therapy.
Yeah,
I agree with you.
Yeah. So the thing with trauma is it's extremely different. I think things need to keep trauma in mind, but not actually necessarily to have that there has to have been trauma or something traumatic. That trauma may not have happened, but it's not remembered. Maybe a misattunement, so a mismatch.
That's what I mean. Anyway, I don't want to take up too much time.
No, it's okay.
But it's interesting what you're saying, because I've recently had a young lass looking to shift from an organisation, looking to work with me, and it sounds like her issue is that the clinician is not wanting to find the source of the issue, and that's what she's searching for. So that's really quite contrary.
But a lot of people with trauma they can't remember their childhood anyway, so we're not looking for memories, and memories can be rubbery anyway, so...
It doesn't have to be a memory, though.
That's right. It's often more procedural body memory, a flashback, that sort of thing that people start to understand. And so that's where the sensory motor psychotherapy that I was talking about is really great, because it can work with those non-verbal aspects without talking about trauma. We don't want to talk about trauma necessarily.
Yeah. No, I absolutely take your point. I mean, I think as a whole, I think that the understanding of the interplay between it all is evolving. And so some of the techniques you're talking about could absolutely be useful. We haven't gone down that route yet.
Well, I think we have actually.
Yeah,
we have.
You're talking about the neurofeedback?
At Spectrum we have.
Yeah.
Done circus groups and psychodrama and all sorts of things in the past, and tried to have a multi-pronged approach to work with it. And that seemed to be pretty effective for people who couldn't sit in a room and just talk to somebody.
Yeah.
Just from a systems perspective, it's in relation to mental health generally rather than BPD. My sense is that it's an emerging capability across the sector to develop a capability in being in trauma-informed practice, which I understand is to be sensitive to everyone brings some level of trauma in their life across whether you're in the mental health system or not. So, but especially if one's in the mental health system, that one can hopefully be in a relationship with whoever your is empowered to give you a service, that they will be trained you to be sensitive to make sure that they don't exacerbate if any trauma from the past. And that's my understanding of trauma, what trauma-informed practice is. So it's not so as a base.
Yeah. So it's not so divorced from the common factors then, is what you're.
Yeah. So again, it's a system-wide
Yeah.
capability that maybe is a new base of
Yeah.
what's standard of what should be expected.
Yeah. No,
Is that a way of tackling that discussion? Yeah.
I'm aware that we're heading on for 7:30, so maybe just one more question.
Just like to draw attention to the fact that, those common factors are probably, we're capable of addressing those in specific settings, but in the public mental health system, for example, there's KPIs to be met, there's all sorts of time pressures. So in terms of the actual skill, the empowerment of people just thinking of themselves as being practitioners in that sense, and also the time factor of the number of sessions that are possible to have. They're always going to be governed by other priorities, such as okay, this medication is working, so they need to be discharged onto the GP or whatever, or with some psychologists, number of sessions that can be allowed to be done. So those limitations really apply. We all like to think that is what we're here for, but whether we're actually able to do that, there's a lot of work to be done to actually facilitate that.
Oh yeah, it's a massive systems issue. And so in putting these up here and talking about it, I often worry that it's going to be perceived as me saying people aren't doing this, and that is actually just the opposite. What I'm hoping people get out of this is that I think you're probably all doing it, and that you should think of yourself as being highly skilled for that reason. And that's what I was getting at when I was asking about people thinking of this as being a passive process. Because if you ask me, it is anything but. Because this is a very complex and skilled set of criteria that I'm talking about here. And just even if you look at it and you say, well, yeah, obviously, that doesn't mean that it's commonly understood. So I hope that that's the. I'm certainly not even a little bit suggesting that people don't bring an incredible degree of understanding and skill. But I think that it helps sometimes for people to look at it and say, okay, yeah, like this is my structure, this is my framework. I'm working off the common factors. Does that make sense?
I guess that I'd just like to mention some of the work that Project Air Strategy from New South Wales is doing about short-term interventions. Spectrum's also trialling a number of short-term interventions, so there's a 4-week, 10-week, 20-week intervention, which are all sort of pretty well based on that, but they're short-term interventions, waiting really for the person to be readily wanting and able to be engaged in potentially a longer-term therapy. So what Lukas has been talking about, he mentioned the clinical practice guidelines. There's a couple of copies up there. Pretty well all that Lukas has said is in here. I know it's 2012. It's still world best practice pretty well in the guidelines. So you're welcome to take a copy if you like. I'd just like you now to all thank me for Lukas for coming in. He's looked after a sick boy all day.
Just quickly, so if you want to refer somebody to Spectrum, it has to come from a GP or a private psychiatrist. Unfortunately, at the moment, our wait lists are to actually do the assessment are getting out towards 6 months. And from there, treatment, the time that somebody can actually start treatment will vary. But please refer. It's once we see somebody, we really do our best to try and arrange some sort of treatment, some sort of hope that people are going to get some support.
Maybe you can do some advocacy with Greg Hunt, the Federal Health Minister, who recently brought in 40 sessions per annum for people with eating disorders.
Yeah.
I see someone, fortunately, she has an eating disorder along with her personality disorder. So,
Yeah.
so she
Yeah,
can get more help.
That's a whole issue. But we're actively advocating.
Yeah.
So there is a petition out there to sign
Jump people in the queue.
advocating to Greg
Yeah.
Hunt to get 40 sessions under Medicare.
There's a petition?
Yeah.
we've got-
Is it a sensible question to say you do triage?
Second,
You do triage already?
that's my main role, yes.
So currently we've got about 16,000 signatures, I think, altogether for the petition. So hopefully, but there's all sorts of politics happening as well.
Some of the private people. can
So
do it.
you're welcome to stay and to talk and to help us to eat the food, take some resources. So thank you for coming, and I hope you all have a happy festive season and see you back in 2020.